Okay. Now I have the great pleasure of introducing my fellow panelists. You've already met me. Again, I'm Sarah Halter. I'm the Executive Director of the Indiana Medical History Museum. And I also have with me my colleague, Norma Erickson. Here she comes. She's our education manager at the Indiana Medical History Museum. And we also have joining us Justin McAfee, who is the Education and Community Liaison Director at the Indiana Family and Social Services Administration. Unfortunately, Katrina Norris, who was going to join us this evening, was unable to make it, but Justin has stepped up to give the presentation in her place, and we're very grateful to him for being here. I want to tell you just a little bit about each of them. Norma Erickson is a graduate of IUPUI with bachelor's degrees in religious studies and general studies with a concentration in math and science. She has a Master of Arts in U.S. History, where her thesis focused on African American healthcare in Indianapolis at the turn of the 20th century. Previously, she worked as an analyst in clinical, forensic, criminal justice, and athletic drug testing laboratories. And most recently, she was the managing editor of IJHAC, a journal of humanities and arts computing, and also the assistant managing editor of the recently unveiled digital version of the Encyclopedia of Indianapolis for the Polis Center at IUPUI. As a volunteer, she began giving tours of the old pathology building way back in 2004 and is now employed as the education manager, as I mentioned. She's author of Ted Hartley, A Half Century Behind the Wheel. Norma's a racing fan. This was published in Racing Cars magazine. And she also authored, among other things, Extending Helpfulness, Carl G. Fisher's Philanthropy to African Americans. That was published in Traces of Indiana and Midwestern History. And Justin McAfee is, again, currently Education and Community Liaison Director at the Neurodiagnostic Institute, as well as a trainer for the State Hospital Network's trauma-informed rollout. He has a very interesting background. I'm fascinated by this. He has language and culture certificates from Miyazaki University in Japan, and he is also an alumnus of Purdue University. Justin, has worked in informal science education for years, most recently as a visualization developer for NASA, JPL, Caltech's imagery, and as director of education at Science Central in Fort Wayne, Indiana. He is a back-to-back CILC Pinnacle Award winner and an NOAA Public Engagement Award recipient. He's also an outspoken advocate for science, mental health, and art education. All of those things are so important. So Norma and Justin and I are very glad to have you with us this evening. Thank you again for joining us. Tonight's program will begin with Norma and I sort of tag teaming a presentation about the early theories of mental illness and early diagnoses and treatments and how those evolved over time. And then we'll bring in Justin to sort of pick up where we leave off to talk about the Indiana State Hospital system today, and especially the recent adoption of trauma-informed care across the system. So I'm going to share my screen now again. This time there's no audio to worry about. Hopefully you can all see it. I'm not seeing any shaking heads, so I'll go forward. So I have to start here at the Indiana Medical History Museum. The museum, for those of you who aren't familiar with us, is housed in what's called the old pathology building. It was the pathological department of what became Central State Hospital on the near west side of Indianapolis. Central State Hospital, as most people know it, was the first of the state's psychiatric hospitals. It opened in 1848 as the Indiana Hospital for the Insane. Before the hospital opened, Hoosiers with severe mental illness frequently ended up in workhouses, jails, poorhouses, places like that. Whatever the circumstances, early on, the idea was usually to keep people with mental illness out of sight and out of mind of the public. And asylums, where they did exist, were really more meant to confine people rather than to help them heal. Medical professionals had at times spoken out about this poor treatment of people with mental illness, but it took some time for things to change. Then in Indiana Hospital for the Insane opened in 1848, and it was in line with what was called moral treatment. This was a widespread movement that came in response to humanitarian reform efforts that were led by the Quakers, sort of beginning on the East Coast and moving their way west. And also an emerging idea in medicine that mental diseases were just that. They're diseases. They could be studied and treated, at least in theory, just like other diseases could, given the limitations of medicine at the time. So this is a postcard of the hospital, the original hospital building. It's undated, but it depicts the hospital as it appeared once it was complete. It actually opened before it was completed. And this building later became the Department for Men. So you can see it's portrayed here as a very idyllic place. It's calm and peaceful. It feels more like a sprawling country estate than it does like a place of confinement. And that was the idea. It was also no doubt the intention. But the image projected to the public really painted the hospital as a place of refuge, rest, and healing. They took great care not to give the impression of incarceration. The moral treatment movement really held a non-judgmental view of insanity, meaning that it didn't attribute mental illness to failures on the part of the patient, which was kind of a change in thinking. It described mental illness as a morally neutral disturbance. So this was an early attempt to get away from the asylum system that had been in place before, and to get away from the idea that people experiencing mental health issues were just innately bad people, or that they were being punished by God for moral failings, or that they were, possessed by demons, or worst of all, that they were beyond hope and unworthy of help. They really stressed that the importance of building trust with the physician and the family, keeping the best interests of the patients in mind. Proponents felt that what the mentally ill needed in order to recover was isolation in a very strictly controlled environment, away from the stresses and bad influences that were causing their psychiatric symptoms. It stressed that with more care, with structured daily lives, beautiful architecture and landscaping, lots of fresh air and sunshine, and at least basic medical care, that people's symptoms and their lives could improve. So these were sort of the treatment that was offered, along with the physical and mental health benefits of work, amusement, and sort of a feeling of home that they hoped the patients would feel. So this was a powerful idea, and just using the word hospital in the institution's name implied that the goal was to help people get better, not just confine them for the convenience of families or communities. And these early supporters of the hospital bragged that 8 or 9 patients in 10 would quickly recover and be returned to their families as productive citizens. The rosy picture that they created and their lofty goals were just not reasonable. They were just not reasonable expectations, because as it turns out, though this was a huge step in the right direction, it was largely ineffective. It did provide more humane treatment for people with mental illness, and for a lot of people, much improved living conditions. It certainly eased burdens on families, and it started a slow change in public and medical perceptions about mental illness and the people who suffered from them. But with a complete lack of understanding of the nature of these diseases and no real effective arsenal of therapies, there just wasn't a whole lot that physicians could do. Many of the staff, including doctors and nurses, attendants, they were poorly paid, poorly trained, and poorly equipped emotionally to handle the high stress situations that they found themselves in. There also weren't enough of them to go around, as the hospital pretty quickly became overcrowded, and it was perpetually underfunded. And there's another layer of failure that is always important to mention, though a thorough examination of this really would take far too long. It's beyond the scope of our program tonight. But almost from the beginning, allegations of abuse and neglect were pretty widespread. There were also problems with nepotism, political cronyism, mismanagement, and misappropriation of funds. All of these things were commonly alleged and often found to be true. And Norma is going to talk more about this image in just a bit, but this is from the Indiana Crazy House, which was a short memoir published in the 1880s by a former patient named Albert Thayer. He originally wrote in the newspapers. These were editorials, and he just had a scathing review of his time spent at Central State Hospital, what we now call Central State Hospital. He witnessed a lot of horrors there, and he sort of wanted to call public attention to what he'd seen. Not everyone who was a patient there had such a terrible experience. I think that's important to acknowledge, but it's also true that Albert Thayer was not alone in his experience. Hospitals like Central State were expensive to build and operate, even when they were cutting corners. And in the last 2 decades of the century, other state hospitals began popping up around the state to kind of ease the burden, to kind of reduce some of the overcrowding that was at what was then called Central Indiana Hospital for the Insane. This resulted because that quick recovery that a lot of people predicted just wasn't happening. So these hospitals would fill up with patients who weren't likely to go home quickly, if at all. As one hospital filled up, another would be needed. So it was becoming clear to everyone, patients, administrators, doctors, and the public, that moral treatment just wasn't working. It was failing, and that a new approach was needed. So in the early years, what we now call psychiatrists held this view that there was really just one type of psychosis, and that it manifests itself differently in different people or at different times. And though, as I mentioned, they held a non-judgmental view of mental illness, they still thought it was pretty incurable because it was thought to be hereditary in many cases. So these sort of shifts in thinking, and the realization that things weren't working out the way they wanted, that was influenced in part by theories of eugenics and evolution, and to some extent phrenology, led to some big changes. As moral treatment faded, biological psychiatry became more dominant, and institutions who often no longer felt that mental illness could be cured began to turn their focus to research. In 1896, Dr. George Edenharter, who was superintendent of Central Indiana Hospital for the Insane, established the pathological department, which was dedicated to research on the physical or organic causes of mental illness, like tumors, lesions and circulatory problems in the brain, traumatic injuries, congenital defects, degenerative diseases, all of these things. Doctors performed autopsies on the deceased patients to study and hopefully better understand these diseases, and with hope of finding treatments eventually. Dissections and pathology weren't enough, though. Autopsies were useless without a proper diagnosis and without details of a person's life and descriptions tracking their symptoms over time, as well as their prognosis. At this same time, a new age of experimental psychology was emerging that stressed observation and recording on the contents of a person's inner experience. Statistics about admissions, discharges, and deaths were tracked, as well as demographic details like birthplace, religion, occupation. And all of this would make it possible for more systematic and scientific categorization of mental illness to be developed. And at Central Indiana Hospital for the Insane, both of these ideas were embraced, as is evident in the later annual reports, which kind of evolved as psychiatry and neurology developed, and as you will see next from Norma Erickson. Norma, you're muted.
No, I'm not. Thank you. I also forget attachments. We're charged with looking back a bit at the patients and what we know about the patients in the past. And if, particularly as it comes as it's related to trauma. And I'm not going to talk much about the definition of trauma because I'm pretty sure Justin's going to be doing a lot of that, but I had to have a place to start with that. So some of the reasons we look at today of a cause of emotional trauma is workplace, on-the-job accidents, vehicle accidents, childhood physical, emotional, and sexual abuse, childhood neglect and abandonment, natural disasters such as earthquakes, tsunamis, fires, military combat, sexual assault, physical assault, and also witnessing violence. So these are what we think of today as experiences or events of emotional trauma. So the question we had were there points in the history of Central State Hospital when those in charge of treatment were looking for instances of emotional trauma that may have entered into the patient's lives? So that's what I was at. Now, the next slide, Sarah. As she was mentioning, the reasons for mental illness, the names for the kinds of mental illness evolved over the years. And when Philippe Pinel in Paris put forth his moral treatment ideas, and also he was in charge of the lunatic asylums in Paris, there were really only 4 classifications of mental illness: melancholia, depression, mania, dementia, and idiotism. That was it. Between 1845 and 61, there were 6 different types of melancholia that was defined. And then, of course, in the 1880s and 1890s, there were many more descriptive and discrete examples and classifications of mental illness. So let's look at 1853. When it comes to the question, were they looking for reasons? That was apparently all they had in order to classify insanity at that time, was what had happened to this person. So these are different reasons why people were in the hospital and what their probable cause of insanity was. So you see several things there, and this is where if we had audience participation, people would be mentioning certain ones. Some of the ones that I thought were very interesting was husbands in California. It's 1853, it's the gold rush. Guys are gone. So those are some of the areas. The next slide, I focused in on ones that I thought really sounded like this would fit what we think of as trauma. There were 653 cases on that report, but none of them mentioned childhood trauma at all. But some of the big ones were domestic dissensions, ill treatment by relatives, abuse from drunken husbands, seduction, fright. The spiritual wrappings was really in the top 5 of reasons why causes for insanity, outside of unknown. So unknown, 71 cases was the highest number that they just didn't know. Next slide. And here we see, this is Dane in a book he wrote, by 1860, heredity was considered the most likely reason for insanity. And all the things that we looked at were just manifestations of that insanity. But they looked at people as either having inherited the insanity or perhaps inherited the predisposition for insanity, or something had happened to them, like poor upbringing or hard work or things like that, that would, if they had a trigger, then that would be the reason for their insanity. And if there was no clear trigger at all, heredity was assumed to be the reason why they were insane. When we move up to 1924, remember I said that in the 1880s and 1890s, there were more clear descriptions of what was the cause of the mental illness, or the description of the mental illness. So in 1924, we don't see those reasons anymore, that same kind. They just didn't report on that. They actually reported on things that were a lot more focused, like drugs and epilepsy, which of course is not a mental illness, but there are situations that a mental illness can develop from that because of perhaps prolonged seizures that cut oxygen off to the brain or something that might cause a problem. So some people with epilepsy were in the Central State Hospital. And for them, 212 unknown. And that's okay. Go ahead, switch. So these are the more medical reasons, I guess I'll say, or with psychiatric labels. Dementia precox was schizophrenia, cycloneurosis, manic depressive. Constitutional psychopath is what we would call antisocial person today. Involution had to do with menopause. And then paresis down there again was that end stage of syphilis with loss of mental capacity, paralysis, hallucinations, and then unclassified. Now, not just having trauma that causes or precipitates mental illness, also trauma in institutional care was, as Sarah already mentioned, a big problem, where the moral treatment was supposed to remove some of these things from people to make their lives more calmer. By the time we get later on, that seems to not have been as big of a focus as would have been before. These writers all were later 19th century and then mid 20th century. Albert Thayer, Anna Agnew, who wrote Under the Cloud, we'll see her picture in a moment, and Raya Fagan Cox wrote an essay, I Remember Jones. These are all patients that wrote. And she already mentioned Thayer a great deal about he had written pamphlets, not just this one, but another one. And in it, he gave very vivid descriptions of beatings, as this is a line drawing that was on his pamphlet of a patient who apparently was doing nothing but sitting on a bench, and two attendants came up and started wailing on him. He also had a written statement from a woman who had been discharged of her receiving beatings from the attendants. It's not from the other patients, but from attendants. And one was so bad that the attendant actually ripped the woman's hair off her head and her skull was showing, just scalped her. So these kinds of images this Thayer brought forward to say that there was something just really terribly wrong with what was going on at Central State Hospital. And one of the biggest things he thought it was the fact that the people were not well trained. They were not, they didn't have, I guess, the caring and compassion to be there because of their political persuasions, because these jobs at the hospital, since it's a state hospital, when the political leaders changed, they would appoint different people as a superintendent, and even cronyism with other people who were attendants and the doctors and things like that. And he pretty much thought that was a big problem, because a Republican should not be taken care of by a bunch of Democrats, and a Democrat should not be taken care of by a bunch of Republicans, which, wow. So that was one of his things. And he was appealing to the governor and the lawmakers to make a law and remove that hospital from the political system completely, so that the right people would be running the place. And Anna was a patient there for several years. Her book, From Under the Cloud, came from a conversation she had with one of the physicians there about whether would she ever get better again. And he said that someday the sun would shine and he would come out from under the cloud. And so that was what she wrote this memoir. And it's very heartbreaking because she lost her children because of her condition. And she was always very sad. She thought even as from childhood, and always had in the back of her head that probably she shouldn't live. And there were things she did that landed her there in Central State. And in some ways, she praised her attendants. She had a couple that were very kind to her, but if they would go away, then these other ones would come in, and she received beatings, and she was restrained very tightly by a couple of them. She admitted she needed to be restrained because she had tried to hang herself there at the hospital. And so at night they would put restraints on her to keep her tight, keep her in place. But it didn't have to be tight and restricted and put marks on her. So those were the kind of things that happened to her, and also beatings and just general condensation by some of the attendants that were there. But it's it's a really good memoir of her experiences there. Rhea Fagan Cox, she wrote an essay from around the 1950s. She was in there for a few years in Central State Hospital. And most of what she complained about for her, the treatment that she received there, was one particular attendant named Jones, who didn't beat her, but was such an enormous bully to her and pushed her around. And it was like she thought it was a point where these attendants who were not very educated and lower class were taking it out on upper class people. And as I said, she wasn't beatings, but this attendant would tell the doctor things about her that Cox felt kept her from being released, or from being moved to a different area where things were better, or something like that. So that was a different kind of trauma that she was experiencing as a patient at the hands of an attendant. That's all I got.
I'll take it from here. So as you saw, by 1924, there really had been a pretty big shift in how psychiatrists viewed and studied mental diseases. Theories were now focusing more on a biological basis for mental illness, given that they really had little to no understanding of biochemistry. It really, in this sense, biological is really anatomical. But they were changing the way they were looking at the problem, and there was also a change in how the diseases were categorized, as you saw. At this time and in the years before this, there were enormous advances in medicine and surgery and science generally, and in hospital care and in research. But at the same time, as Norma mentioned, this is coming out of a time when mental illness was really thought to be largely hereditary, and in many cases, physicians and psychiatrists really had little hope of recovery for their patients. So for all of these reasons and others, and despite the advances seen in other areas, actual treatments for mental diseases were really not advancing a whole lot more than they had previously. There were some treatments for specific diagnoses in the psychiatrist's arsenal. It wasn't that there were no new advances, but most of the care was still either palliative or nursing care, and it focused a lot on comfort and relief from pain or other physical symptoms that the patients had. So nursing care was really important. The feeding, sedation or other treatments for insomnia, catheterization, or methods to relieve constipation, prevention and treatment of bed sores, and other means of just relieving these physical symptoms that the patient might be experiencing. They were all very important. And these, for some patients, were more real to them because there was a more real and immediate benefit to them that they could see and feel. Some hospitals, like at Central State, from the beginning, used something they called occupational therapy, and this is occupational in the sense that it kept patients occupied. So it's not exactly what we think of today, at least not yet at this point. There were organized activities for patients to watch or participate in, and many patients also worked on the grounds, helping with farming, making and repairing clothing or other textiles, or working in kitchens or in the carpentry shop, for example. And by the 1920s, this was evolving somewhat, and patients who could work were starting to be assigned jobs based on the needs of the hospital. This was also an attempt to be self-sustaining in a hospital situation where funding was very important and very lacking. But patients were also assigned based on the needs and talents of the patients themselves. So physicians and administrators tried to pair patients with jobs based on their previous expertise or occupation, as well as their physical, social, and psychological capabilities and needs. Hydrotherapy was also still very common in psychiatric hospitals. This is one that had been around and very common since the beginning. Various ways of applying hot and cold water to stimulate or to sedate patients were used, sometimes with massaging, douches, etc. These were commonly used for patients experiencing mania, but they were used, for other afflictions as well. There were also light therapies that were used at Central State and other hospitals, endocrine therapy, opium and morphine. Other places, I'm not sure I've ever come across a reference to this at Central State, but there were places that were using hypnotism as well. One specific treatment for a specific disease, this one's my favorite, so if I'm smiling inappropriately, that's why, is malaria therapy for neurosyphilis. It's a fascinating idea to me that one deadly disease could be used to treat another, and it's something that I've spent a lot of time researching. I'm going to try to give you the short version here. It goes something like this. During World War I, after noticing that patients in a psychiatric hospital in Vienna saw improvement in their symptoms after recovering from certain fever-causing infections, a doctor there began experimenting with malaria as a form of therapy. So patients with neurosyphilis, usually were coming to places like Central State Hospital for sort of final care. They could expect to be dead within a couple of years, usually, at most. This tertiary form of syphilis couldn't be treated with arsethylamines the way that earlier stages of syphilis could. And so patients were infected intentionally with a weak strain of malaria. This was one of the few infectious diseases at the time that could actually be treated. This is before, antibiotics. It was before the sulfa drugs. And so really quinine was it. So they used a weak strain of malaria. They induced cycles of fever and then treated the patient with malaria or with quinine to get rid of the malaria. And it's more complicated than that. I don't have a lot of time, so I'm trying to keep it short and simple. But the results were pretty positive generally, particularly if treatment began before a lot of damage had been done to the brain. There were some issues, of course, for example, with secondary infections that were introduced along with the malaria accidentally. So it's a complicated story, but it was clear, though, that, when they started this treatment early in patients, they did see marked improvement. And what really was debated was the actual mechanism by which it worked. It was first used at Central State in 1925, and they were among the first in the United States to use it. And by the late 1940s, early 1950s, it was pretty thoroughly replaced by penicillin. And then, it was in the years and decades after this period, this 1924 date of the annual report, you saw that treatments really began to change, and more types of therapies were being developed that really aimed at relief of the psychiatric symptoms. Shock treatments were the first. Central State introduced those in 1938. They used insulin and electric shock first, and then added metrazole. All of these kind of induced convulsions and comas. They were, replicating epilepsy. And they did see psychological changes in the patients after the treatment. They were first advised for alcoholic and neurotic patients, but pretty soon after shock therapies were introduced, they were very commonly used to treat schizophrenia. Insulin and metrazole shock therapies were not preferred at Central State for a couple of pretty good reasons. The convulsions and coma did not come quickly. This is a good example of a treatment that could itself be traumatic. So for a time after the injection, patients often experienced periods of very intense fear, and just sort of general unpleasantness. And over time, they also found that the insulin and metrazole shock were just less effective than an electric shock or ECT. And the effects lasted less time. Psychiatrists at Central noticed that delusions, hallucination, catatonic postures often disappeared or at least lessened for a time after the patients, and many of them were able to return to something closer to a normal life after treatment. There were a lot of ways that the hospital environment caused trauma itself, and Norma talked about a lot of those. But shock therapies were really kind of both at the same time. It was a kind of a physical trauma to the body as well as a psychological trauma, even with the ECT, which did have an effect more immediately because the patient undergoing the treatment at that time was not sedated, and rather they would be held down by a group of people, sometimes including their fellow patients who were sort of enlisted to help. And so it could be physically and emotionally exhausting, to say the least. Then in the 1940s, prefrontal lobotomies became popular in the United States, and a lot of people were sort of rushing to have their loved ones lobotomized inside and outside of psychiatric institutions, but they were never performed at Central State Hospital. The superintendent at the time, Dr. Max Barr, banned them for a couple of reasons. He felt that their efficacy was questionable and that they were prescribed way too casually and too often. And he also recognized that Central State just didn't have the capacity to accommodate proper recovery after the procedure. He didn't have enough extra recovery beds and nursing staff to really help people recover from the procedure. So they never were done there. It doesn't mean it didn't happen to patients there. Some may have been lobotomized elsewhere before they were admitted to Central State. And it was also possible for families or doctors to pull people from the hospital, have the procedure done elsewhere, and then kind of bring them back after the recovery period. And patients might be deemed eligible for that if no other treatments had worked. And I won't go into a lot of detail about this procedure, but if you're curious, and I know you are, we do have an online exhibit on our website right now about lobotomies and Central State Hospital, and it does include some interesting video footage. Next, in the 1950s, came new drug therapies. Before we had narcotics, pretty much. But in the 1950s and 1960s, even though there really were only a handful of these available, there were these new things on the market. They were one of two types. There were tranquilizers, and then there were neuroleptic or antipsychotic medications, which include LSD. Tranquilizers were the most commonly prescribed and the better understood in a lot of ways. They certainly did less permanent damage than a lobotomy, but they did have serious side effects, and some of them were even pulled off the market later on. But it was, less common for the antipsychotic medications to be used. And when those were used at this time, it was frequently in conjunction with psychotherapy, which, they felt that the antipsychotic medications could sort of open up patients to make psychotherapy more effective. Shock treatments, by the way, were also used for that same purpose. They were very commonly used in combination with psychotherapy for schizophrenic patients. And that began really as soon as these shock treatments were widely available. And then, in the 1950s and 60s, there was a push to get acute patients out of these hospitals altogether to find outpatient care for them within their own communities. And that's, this trend towards de-institutionalization is a whole other program. So we will just leave it at that. And this is where I will let Justin take over and sort of bring you up to date. So I'm going to stop sharing my screen.
Beautiful. All righty, well, let me start sharing. Outstanding. Let's see. Well, that was so cool. Thank you so much for what an informative ride. I felt like I've been on a journey here. I feel like I've learned so much. Thank you so much for all that research. That was fascinating. Once again, my name is Justin McAfee. I'm the Education Community Liaison Director for the Neurodiagnostic Institute. If at any point during my little talk here you become emotionally affected by any of the material herein, please feel free and take a break any time. Let's go over a quick overview here. We have 6 state hospitals in the Indiana State Psychiatric Hospital Network: the Evansville Children's Psychiatric Center, or EPCC, the Evansville State Hospital, Logansport State Hospital, Madison State Hospital, the Neurodiagnostic Institute, or NDI, and the Richmond State Hospital. So we currently admit and discharge about 600 patients each year throughout the whole network. Patients come from a couple different places into our network. Some come from our behavioral and community health partners in the community, and some will come to us by way of civil commitment or justice referrals. These civil commitments are sometimes referred to as forensics. So, children really are the only patients, as minors, considered to be voluntarily admitted. Let's go through some of these hospitals that are still around today. As we know, Central is not. So let's go around the network here. Madison State Hospital was established by legislative act in 1905. Construction was completed in 1910, and the first patients were transported via train on August 23rd, 1910. So we are 111 years old, as Bilbo Baggins in The Lord of the Rings might say. 111 years, and for a large chunk of that, Madison State Hospital was self-sustaining, like most other state hospitals at that time. So Madison had a vineyard, and it produced wine, as well as had dairy cows and turkeys and orchards on ground. Richmond State Hospital sits around 120 acres today. The largest physical campus, as well as the highest number of beds for the network. All patients are housed in the residential treatment center, and patients' treatment needs are met with inside that treatment mall. Thus, no one has to walk between the buildings for treatment, which is great. Richmond has the state's only independent transitional living home that mirrors the group home settings to assure that patients can safely transition back into their home community, which is very, very cool. It says the right thing. After 130 years, the administration building, the 3 adjacent to it, and 2 other buildings are the only ones to have survived from the original plans. Logansport, that's today kind of known for their forensic capabilities. So sometimes we'll refer to them as the forensic hospital, as they have specialized training programs to work with the state's most dangerous patients. The campus today shares the campus with the Indiana Department of Corrections, and in 2021 here, Logansport had their first female superintendent appointed, which is pretty awesome. Logansport, along with Evansville and Richmond, in 1883, were kind of commissioned. It's a 160-acre tract of land by the Andrew G. Schenkel Farm, 1 mile southwest of Logansport, and it was selected and purchased on October 4th, 1883. The citizens of Cass County also donated a number of acres, so totaling 281 acres owned by the state of Indiana, which is pretty great. Hospital opened in July 1st of 1888, receiving 309 patients. The Isaac Ray Treatment Center opened in 1979 and is the sole source provider for forensic psychiatric services for the state. We also have the EPCC, or Evansville State Hospital, one at a time. The Evansville State Hospital today sits on adjoining grounds with the beautiful park operated by the city of Evansville. Evansville State Hospital is also known for their specialized programming and care of the geriatric patients with severe mental illness. It opened in 1890 as the Southern Indiana Hospital for the Insane. Some people also knew it as Woodmere. It served counties in the southwestern Indiana. The idea being that if patients had friends and family that wanted to visit, you wouldn't have to travel too far. There was a fire there in 1943 that closed the hospital for a couple of years, wherein all the medical records were actually destroyed, which before digital was just an unfortunate part of fires. As I'm sure any historians here might be able to commiserate with fires burning away so much of written history. Reopened in 1945. EPCC, or the Evansville Psychiatric Children's Center, has a premier child and adolescent program for youth under 13 years of age. Their parents have an average, or the patients have an average length of stay of around 4 months. It was founded in 1966. It was designated to be one of several state-operated facilities to serve Indiana's emotionally disturbed children. However, it was the only one of these facilities that was fully completed and open for services. This past October, the EPCC celebrated its 55th anniversary. And my personal home base here, the Neurodiagnostic Institute, or NDI, opened in March of 2019 and serves the State Psychiatric Hospital Network with the shortest length of stay of any state hospital. The average length of stay for patients is around 90 days. The Neurodiagnostic Institute and Advanced Treatment Center, located on the campus of Community East Hospital in Indianapolis. We have 159 beds. NDI delivers advanced evaluations and treatments for patients with the most challenging and complex neuropsychiatric illnesses and serves both adolescents and adults. The NDI is a key component in the Indiana Family Social Services Administration's initiative to modernize and re-engineer Indiana's network of state-operated mental health facilities. Now that we've talked a little bit about each hospital, let's talk about the historical treatments implemented at our hospitals here. I have some pictures here. Hydrotherapy, we were talking about that earlier. Recreation therapy down at the bottom left there. Richmond State Hospital actually had a fully functional bowling alley on campus until just about 20 years ago. And down on the right there, you'll see the electroconvulsive therapy, or ECT machine. All therapies have served a purpose throughout the history of the state hospitals. All have needed to evolve over time with more research and evidence-based recommendation. For example, that ECT machine seen here might surprise you that it's not the same one or kind that we use today. Also, since the late 1950s, practices like anesthetizing patients for their therapy is now part of the procedure. Hydrotherapy, otherwise known as kind of needle showers, continuous baths. Those were the first treatments in the 1900s. Convulsive therapy was introduced in the 1930s, and it is still used today, and it's actually extremely effective. It can be extremely effective for severe depression. I think around the country, there's around 100,000 people that use this therapy, and for severely depressed people, it has a success rate of about 80%. It's really cool. Insulin shock therapy was used until the 1960s. Surgical procedures, we talked about the lobotomies. Today, the use of psychotropic meds in conjunction with multiple other therapies like dialectical behavioral therapy or cognitive behavioral therapy, psychoanalytical approaches, those are the primary treatments utilized. De-institutionalization. With improved medication, treatments, and Community Health Act of 1963 came about, and the trend to kind of keep the mentally ill hospitalized in large institutions began to kind of reverse itself. So those state psychiatric hospitals were closing across the nation. Some states got rid of all of their state hospitals. Indiana has since closed 7 of these facilities: the Norman Beatty Memorial Hospital, Central State, Newcastle Developmental Center, Northern Indiana Developmental Center, the Muscatatuck State Hospital, Silvercrest Children's Developmental Center, and the Fort Wayne Developmental Center. Those have all since closed. Over 500 patients with a capacity for around 600 with current remodeling. That's right. A lot of state hospitals are being remodeled for ligature and kind of safety protocols. We're currently remodeling a lot of those. Upon completion of those, we should have the ability to house about 800 patients. Currently, we do have more males than females. In the past 20 years or so, we've had a pretty large increase in forensic referrals to our network. But obviously, we continue our commitment to quality care. The recovery model. That's what we've been kind of using. The concept of recovery is about staying in control of your life rather than an elusive state of a return to pre-morbid levels of functioning. Such an approach, which doesn't focus on full symptom resolution, but emphasizes resilience and control over problems in life. That's really been the model that we've been working with. The approach argues against the treating or managing of symptoms, but focuses on building resilience of people with mental illness and supporting those in mental distress. So we emphasize hope and hold a strong belief that it is possible with people with a mental illness to regain a meaningful life despite persistent symptoms. So you might also hear recovery being referred to as a process. That might be familiar to some of you. So trauma-informed care. And this is the new model that we are implementing on top of that recovery model. It's a model that understands and considers the nature of trauma and promotes environments of healing and recovery rather than practices and services that may inadvertently re-traumatize. So a trauma-informed system is what we in the psychiatric network here in Indiana are moving. Any system that moves towards a trauma-informed program will have 4 R's to it. A trauma-informed program realizes widespread impact of trauma and understands potential paths for recovery. It recognizes the signs and symptoms of trauma in clients, family, staff, and other involved with the system. It responds by fully integrating knowledge about trauma into policies, procedures, and practices. And it actively resists re-traumatizing the patient's staff, everyone. 4 R's. Now, we've been talking just a little bit about trauma, so let's maybe have a full definition of it. SAMHSA defines trauma as individual trauma, results from an event, series of events, or a set of circumstances that is experienced by an individual as physically or emotionally harmful or life-threatening, and that has everlasting adverse effects on the individual's functioning and mental, physical, social, emotional, or spiritual well-being. Now, that's a big chunk, and I don't want you to walk away thinking that you need to memorize that elevator. So I have highlighted 3 words there. They all begin with E: event, experience, and effects. Every traumatic event in someone's life. There is an event, there is something that happens. The experience of what happens, which can sometimes determine whether or not it's traumatic, has effects on people. So events, experience, and effects, that's what makes up trauma. And you might wonder, well, sometimes terrible things happen to people, but why would we focus so much on trauma at a state psychiatric hospital? Well, let me take you back to your high school biology class for 1 second. You guys remember making this shape? This is the shape of your brain, if you're trying to memorize it for a test. And right in the middle here, we have the amygdala and we have the hippocampus. Now, the hippocampus is where all your short-term memories are stored, and it's also what attaches that fear and that context to those short-term memories. Now, right next to that is your amygdala. Now, your amygdala is like your fire alarm for the brain. So when it gets triggered by some emotional response, it detects stimulus that could be threatening, life-threatening even, elevated levels of cortisol levels pump up. It can tell the adrenal glands, which are on your kidneys, the top of the kidneys, to start firing. And you can have a fight, flight, or freeze response. Now, that amygdala there, that hippocampus there, those things are developing really early on in a human being's brain development. The prefrontal cortex, this front section, that's where all the executive functions come. That's where all of the cool thoughts, the emotionals, the regulation of emotions, the regulation of actions, that's where all of that comes about, that front part of the brain. Now, that front part of the brain is really sensitive to things like the amygdala response. So when things get really scary out there, that flight, fright, or freeze can take over. That amygdala hijacks the brain. And when it does that, it can actually shut down your ability to use that prefrontal cortex to make rational decisions. And again, the prefrontal cortex is also something that develops really early in childhood. And we know with a lot of amygdala responses, with a lot of trauma in someone's life, it can actually affect the development, the physical development of the brain. Some statistics. Trauma prevalence in children. 71% of children who are exposed to violence each year. 3 million maltreated or neglected. Up to 10 million witness violence against their mother each year. 1 in 4 girls and 1 in 6 boys are sexually abused before childhood. And 94% of children have an experience of trauma when in the juvenile detention system. A couple more. Up to 80% of school children experience bullying. Up to 93% of youth entering the juvenile justice system have experienced trauma. And 92% of youth and 77% of youth in non-residential mental health treatment report traumatic events. So it's safe to assume if you run into a kid, whether it's in a state facility or not, they have a history of trauma. And that's the same for adults. 84% adult mental health clients with histories of trauma. 50% or 25% of males experience sexual assault in adulthood. So how do we get to a trauma-informed system? Well, we start with trauma screening at all levels of our hospitals, and then we work to address any potential re-traumatizing policies and procedures at all levels. So we're not just interested in being trauma-informed patient to patient or patient to staff, but at every single level of the hospital. So staff to staff, admin to admin, paper pusher to paper pusher like myself. On and on. That's extremely important. Training is also vital when trying to promote a trauma-informed system. So lots and lots of training of all staff. Consistency is also huge, not only in the rollout, make sure that everyone is properly trained, but in the dedication and commitment to change at every level. So it's a paradigm shift. It's a change. Our network is changing. And we must shift with the trends to meet the needs of Hoosiers with severe mental illness and substance use disorders. And that's what we've been up to since this trauma-informed system rolled out. Really kind of during the pandemic. Quite interesting timing. Some resources. And that's me. Thank you so much. That's what I have. I will I'll pass this screen back.
Thank you so much. That was wonderful. All right, we do have a couple of questions. If anyone else has questions and you haven't posted them either in the chat or the Q&A feature, either is fine. Go ahead and do that. And see, the first question here is for you, Norma. Did Anna have depression? Anna Agnew. Are you still with us?
I am. I just unmuted and I haven't clicked my video yet.
I didn't know if maybe you switched over to watch the State of the State address.
Yes, I think that was what the one of the things it was about her. That there's also another book besides the book she wrote. And I should have brought this up. Dr. Lucy King, a retired psychiatrist, went back and looked at Anna's life and her experiences and looked at some of the prognosis and for a patient like her today. So that's a very interesting book you might want to get a hold of if you can't find. Actually, Anna's book is online. It's been digitized and you can read it online. And we have we don't have copies of the Dr. King's book to sell because it's sold out after 2 printings. So if you find one online, good luck.
We do have the copyright for that, and we have looked into having another printing of it done. It just hasn't materialized yet, but stay tuned. And that kind of brings us to the next question. Are there resources in which we can purchase, rent copies of these books and memoirs of the patients? Are there, excuse me. Yes, so all of these I think are available online. I'm not certain actually about Thayer's, but there is a copy of that at the Indiana State Library. And we have copies of it in the collection at the Indiana Medical History Museum as well. They just don't circulate, so you can't check them out when our reading room opens, so you could access them that way. And then, as Norma just mentioned, Anna's memoir is available online. It's been digitized. I don't have the link for that at the moment, but if you email us, we can get that to you. And then Raya Cox, her memoir is available on our website. Let's see, this Nanny Vonnegut, who is Kurt Vonnegut's daughter, Raya is her maternal grandmother, and so Nanny's actually the one that found the memoir in her mother's possessions, and so she has had that reprinted and has given us permission to post it in its entirety on our website, so you can find that there. And then our tour is given of the building that was once Central State. I'm so glad you asked. So Central State was a whole complex. There were a lot of buildings, and there are still a handful of them that are standing. The old pathology building in which we're housed is just one. But we do offer guided tours of the building. The building hasn't changed a lot since it opened. It was cutting edge. It got national attention for how advanced it was in 1896 when it opened. But fairly soon after that, things started to become obsolete. New technologies became available that the hospital couldn't always afford. And so a few updates were actually made during the time that it was a functioning lab. When it closed in 1968, all of that original stuff was left there. And so within a year, it reopened as a museum, and that's what we offer guided tours of. So you can find out more information about the hospital and about our building and how to schedule a tour and all of that on our website. It's www.imhm.org. See. When it comes to NDI, Justin, I think this one's for you. What seems to be the most common type of mental health professional? Psychotherapists, psychologists, psychiatrists, something else?
Sure. Yeah, that's a great question. Actually, in nursing, nursing by a long shot. There are more nurses at state hospitals than any other profession. And those are, from special attendants in nursing to RNs. Any type of nurse that that you can really get your hands on is super valuable at a state hospital. So yeah, obviously we do have psychologists, we have social workers, we have recreational therapists, we have dietitians. We have all those, and they're all wonderful. But if you want the true superheroes in numbers, that's definitely the nursing department.
Someone in the chat asks, who are the princesses in the previous page? It's now many slides back in your presentation there. You probably know what I'm talking about.
Yeah. Those are actually employees that dressed up like some princesses at the Richmond State Hospital for the patients. So they surprised the patients, with a visit from some Disney princesses.
And there's there's also a comment: mental health workers are in short supply. And then the question: what is your estimation of how many more are needed? Do you have thoughts on that?
Oh, I don't know. That's true. You can never get enough good help, and we are in a shortage for sure. Not just at the state hospital network, but really countrywide. So yeah, I wouldn't want to quote you any job statistics as far as like any outlooks. Although I think maybe those do exist somewhere. We could maybe look that up for you. But yeah, we are in a shortage, and we do need people that feel called to it, that have any history or interest. If you think that there's even a chance that you might be interested in doing that kind of work, give it a go. It's super rewarding. It can be super challenging as well, but super rewarding. It's a really good team, especially here. If you come to work for the state, come and work with me. I'm fun, but it is much needed though, and anything that we can do to kind of get that message out there. For people to give it a try, it can be a super rewarding career choice.
Great. A little bit of a tangent here. My sister, a couple of years ago, decided she didn't want to be an accountant anymore, and she left her high-paying goal. It's pretty stressful right now, but she has no regret. She does. So. One of the slides mentioned needle showers as part of hydrotherapy. What does that mean? Do you want to tackle that one, Justin, or you want me to do
Sure.
it?
Well, let me see if I get the basic gist here.
Okay.
The idea with a needle shower was the idea of massaging a person's organs could actually be beneficial and therapeutic. And so there are these contraptions, these pipe contraptions that would be directed, high pressure jets of water would be directed at a person's like kidneys or liver, and then it would shoot kind of like a shower, but shoot those high direct jets at those organs in an attempt to produce a therapeutic result. Yeah, they're interesting. You can Google the images of it. They're quite fascinating. Did I get it right?
You did, yes. Yeah, there were all manner of hydrotherapeutic techniques that some of them kind of scare me a little. Some of them look relaxing and lovely, but let's see. What role, if any, did the 1907 compulsory sterilization law in Indiana have in the treatment of the mentally ill? Norma, you might want this one.
Not really.
No?
No. Yeah, just off the top of my head, I don't think I have an answer for that, because the 1907 law was rescinded anyway, or there was a stand down on that. Didn't really take up again until the 20s. So, and I really don't know for sure. Sorry.
Let's see, we have something else in the chat. What does trauma-informed care look like in practice? Can you give an example of what staff are doing or approaching differently now than they did a couple of years ago before this new program was implemented?
Sure, yeah. And we're still in the process of rolling it out. So we at the NDI, we really started in earnest in training early summer of 2021. So we're just rolling it out. So a lot of conversations are happening at a lot of different levels, conversations that maybe haven't happened before. So I'll give you maybe two ideas of maybe where those could be going. So as far as staff, there is, staff parking lots. You park to go to work. Now, in the past, there have been some kind of hierarchical ideas about who should get what parking space and who shouldn't get parking spaces and have to walk 8 miles in the snow uphill both ways. And so we're really kind of looking at like, what does it look like to open up that parking lot so everyone can kind of have an equal footing? On like a patient level, there are a lot of therapies that can be used in trauma informed that our RT department here uses. So the idea being, if we go back to this model of the brain here, you can actually strengthen someone who has had a very traumatic life, and so that amygdala is just very sensitive. It's a very sensitive fire alarm for when things could go awry. There is a way to strengthen that behavior, and some of it is through physical, actual recreation therapy. So some of that is done here, more of it kind of on the way. You want to have, in a trauma-informed system, you want to have there to be an equality. And an equality not only in the ranks and organization of the staff, but also with patients. So asking patients in the admission process, what do you bring to us? Like, what are your strengths? And really talk about how that can, how we can kind of integrate that into their time with us. So ideas like that are the ideas that are being put forth, and a lot of other ones. But as I said, yeah, we're just starting to roll it out. So it's an exciting time with a lot of cool ideas. Thanks for that question.
Yeah, that was a good one. Thank you. I don't see anything else. Last call on questions. Doesn't look like anyone's typing. Okay, well, we'll wrap it up then. And if you think of any questions, you know where to find us. Thank you both so much, Justin and Norma. This was fabulous. I really appreciate you being here with me to tackle this subject. And thanks to everybody for coming. I know it was a long time coming. So thanks for sticking with us and showing up. Hope you all have a great evening, and I hope that you will come and tour the building.